I'm Pete Van Branken. I'm a veterinarian from Battle Creek, Michigan. I'm here today. I'm chatting with Dr. Jamie Gaynor. He's a veterinarian in Colorado. He's a boarded anesthesiologist. We're going to talk, since he is an anesthesiologist, I'm going to chat with him a little bit today about CRIs, constant rate infusions, something we use in our hospital, and not always sure exactly how to use it, when to use it, and for how long to use it, so I'm going to pick his brain today and figure out a few things for myself, and you'll get a chance to learn a few things too. You know, I see this in our practice. We have a lot of pancreatitis, especially the day after, 2 days after Thanksgiving or any major holidays, usually on Tuesday after Saturday pig roast, things like that. And we still see a fair number of parvo cases. And you know, I think those parvo cases have become a little more challenging as time goes on. So we've had to up the ante as far as how we treat those. And we've been using some CRIs to relieve pain. And sometimes later on we use a little Reglan once we think the pain's resolved as a CRI to help them keep their chow down if they want to go back to eating. And so I'd like a little, you know, I'm never quite sure whether the lidocaine CRIs or the hydromorphones or, you know, I'm kind of curious as to what you think about those approaches.
Well, I think for pancreatitis, every case is really an individual challenge. Some of those dogs, they do really well just with an opioid infusion, either hydromorphone, oxymorphone, even sometimes morphine, except those dogs may get a little more dysphoric. But sometimes opioids are not appropriate. They just don't work, or they don't work well enough. So I think virtually any patient that has abdominal pain can virtually always benefit from a lidocaine infusion. And we throw this term around, CRIs, a lot, and I like to clarify that because people sometimes talk about CRIs as constant rate infusions, and I think it's important to kind of qualify that as a continuous rate infusion because, especially when we're talking about analgesics, the rate can be anything but constant. It may be continuous, but we need to be able to adjust it up or down based on the level of comfort that we're inducing in those patients. So I think those pancreatitis patients, opioids always a good place to start. Lidocaine, I would use lidocaine without any hesitation as a place to start, and then adjust doses within reasonable ranges. But I also think, unrelated to a CRI, an important simple thing for practitioners to do for unresolved pancreatitis pain is putting lidocaine and bupivacaine in the chest, in the pleural space. Because the nerves from the cranial abdomen enter the spinal cord at the level of the thorax. And for those unrelentless, painful dogs, the ones that don't sleep for hours or days at a time, you put a little local anesthetic in their chest, they're instantly comfortable. They go
Really?
sleep. Yep.
Oh, I've never done that before.
Yeah, and you know, it's technically simple. And it's drugs we already have. And so there's always a little trepidation the first time, sticking the needle in a chest, putting lidocaine in, following it with bupivacaine, but it really is that simple. We've been doing it for now well over a decade, probably almost 2 decades. Came from the human side. It is described in virtually every animal pain management and anesthesia book. Good. So it's the technique is readily accessible to learn.
Now, in the parvo cases, you know, lots of times we're adding sugar or glucose in with the IVs, and lots of times, and almost always, we're adding in potassium. Do I have to worry at all with either hydro or lidocaine precipitating out when you're using glucose and potassium in those IV drips or not?
Right, so if we're mixing multiple drugs into a bag of fluids,
right,
in theory, we don't have to worry about a whole lot. You know, clearly if it precipitates, we know it's a problem. The question really is there any interaction that we don't want? And almost always the answer to that is no, but there are actually charts on the web that on one side will list fluids, on the other side drugs, and how they interact in the same bag together. So the pharmacists have figured this out for us. if there's ever any question, it's easy to just go to web and figure that out. There's charts that a lot of the big practices will have on their wall and list all those components. Of course, it doesn't always have everything that we use, but I would say there is almost never an interaction that we have to worry about. Usually the biggest thing is calcium-containing fluids, and if we're using blood products. Okay. That's usually the biggest issue.
I guess the only problem I ever have, sometimes clients come in and visit that dog, and a lot of those dogs are really almost on another planet at the time they come in, because they got all this stuff on board. So they're always kind of concerned about, gee whiz, at least he would open his eyes when I was here, yesterday. And so I think that's always, clients are concerned about their dog being so, out of it. And,
right, and I think that's one of the advantages of lidocaine.
Right.
Because it provides that baseline analgesia, and we can oftentimes use less opioids, so dogs are less sedated, they look more appropriate to their owners, and the owners don't seem to get quite as uptight with us.
Do you have any other things you use other than the opioids and lidocaine? I mean, do you have anything else that you ever use when you have to play when you think you got to play the ace of spades? Or
well, yeah, you mentioned one of them, metoclopramide, yep. Certainly for dogs with GI issues. And I just want to talk about that a second, because usually when we're using metoclopramide, we're kind of locked into a pretty finite dose. And if we've added in some pain-relieving drugs into that bag of fluids with the metoclopramide, now we're kind of locked into our analgesia. So I think bags of fluids are cheap. And if we're mixing things into bags, it may be very worthwhile to have one bag that has metoclopramide going at a lower drip rate with the appropriate dose, and another bag with an analgesic, so that we can adjust the dose of analgesic up and down. Because, once again, if it's all mixed together, then we're really limited on how much analgesia we can give a patient if they need more. The ideal way is, syringe pumps, individual pumps. Not everybody has this whole pump system, but with individual bags and even gravity drip, we can do it appropriately. There are lots of things that we can administer by infusion. So we've talked about some of the opioids, certainly hydromorphone, oxymorphone, fentanyl. We use a drug called remifentanil, which requires no liver or kidney metabolism. Has a duration of 8 minutes when you turn it off. And we use that a lot for trauma patients who may have neurologic signs. So if I want to assess the neurologic status of a patient, I know that if I want to assess that dog at 3 p.m., we turn it off at 2:50, and I can assess the neurologic status knowing that there is no opioid complicating my assessment. We use microdose ketamine a lot. Ketamine in microdoses turns off NMDA receptors. These receptors that are responsible for wind-up central neuronal hyperexcitability. And this is a dose of ketamine that dogs and cats can walk around with, no behavioral effects, but certainly good at helping us reduce the likelihood of problem pain later. So we use a lot of trauma cases, a lot of orthopedic cases, constant rate infusions, or as I should say, continuous rate infusions of alpha-2 agonists like dexmedetomidine, very low doses, synergistic effect with the opioids. So once again, for that problem analgesic patient, the pancreatitis patient, if we add in microdose of dexmedetomidine, get incredible increases in pain control.
Well, I think it's good information. I know that since we've been doing ours, in our hospital, it's really worked well, and I think the telling tale is that the people who provide the nursing care, the technicians, that's almost the first thing out of their mouth. You want to do this, don't you? Right. They're like, they have to spend all day with them back there watching them, so that.
Exactly.
You want to do this, don't you?
And it's the people in the trenches who know whether it's working or not.
So I'm not sure I'm even in charge anymore, because they're already slipping me the answers before the questions posed.
Well, but it's great, because for years I've been promoting the veterinary team as being a necessary way to provide pain control, and really including the technicians and the staff, and wanting them to be trained well enough that they can come to doctors and give recommendations.
Another thing, we've been talking about opioids, kind of prevalent in our practice now is the use of Tramadol. And I'm not sure how much information is available for that. And of course, we're usually prescribing it with nonsteroidal anti-inflammatories, or sometimes with steroids at the same time. But I've sat in on the lectures where they talk about, well, it's a non-opioid opioid. And I always tell the clients, well, it's a non-opioid opioid. And I'm always hoping that the client doesn't go, well, what is a non-opioid opioid? Because I'm not really sure I know what a non-opioid opioid is. It's a sort of like a nice rainy day, I guess, but or sunny rainy day, but it's kind of an odd thing. And what do you know about that? I mean, does it have a decent half-life? Is it a short half-life? Does it really work as well as actually most clients think it does? I think most clients would come back in and tell you now that they may be experiencing a placebo effect of some sort, but most clients come in and say, you did a lot better once you threw the frosting on top of this. Everything worked a lot better. Right.
Well, Tramadol, I call it a sloppy drug. And I say that because of exactly what you've described. It's the non-opioid opioid. Yeah. So it truly isn't an opioid. It doesn't have the molecular structure of an opioid. It really has effects in multiple places. It's a serotonin reuptake inhibitor. It affects norepinephrine. It has some effect on opioid receptors. So it's kind of a weak opioid, has weak opioid effects. There is a lot of debate going on right now. Does it work or doesn't it work? If you ask the pharmacologists, they would say most of us who use it every day, you and me who use it every day, typically will be underdosing these dogs. We're using something like 2 to 3 milligrams per kilogram, 2 to 3 times a day or something. And they would say that to get really consistent plasma levels that should work, we need to be giving it something like 5 milligrams per kilogram 4 times a day. And of course, if we did that, we'd have dogs that are just recumbent. Yep. And I think it really drives home a very important point for we as practitioners to always keep at the forefront and remember that what happens in a pharmacokinetic model doesn't always simulate what happens clinically. And what that means is that the pharmacologists need a different model. So sure, there's always patients that owners think are doing better and it's a placebo effect. But I think there are enough of us who see beneficial effects with Tramadol, especially when combined with a nonsteroidal or a steroid, that we're not all making it up. Now, the problem that we have right now are there really are no clinical outcome studies. And that needs to happen. But it's a generic drug. No one wants to pay for it.
No, that's right.
Somebody needs to do it, though.
When we're talking about nonsteroidals for pain, is there any other drug you use to quote unquote accessorize? Are there any other drugs you use to accessorize with Rimadyl or Daramax or Previcox or any of those drugs?
Well, so we've already hit on it that we use a lot of Tramadol with our NSAIDs. Now, the whole concept of nutraceuticals, I think there are a number of formulations which do work very well for dogs and cats, and we need to be careful. We need, if we're thinking about anything, we really need to be looking for the data, and is the data for that particular product, and it is out there. And I really am kind of a stickler about this, that we need to be evidence-based as much as possible, and in this situation, there is evidence for some products. So we shouldn't just be telling our clients, go to the drugstore and buy something, because there probably is no data for that. But if we look at a handful of products available specifically for our patients, there is real published data to support their use.
When people come in and say, he's really having a hard time getting up and down today. And I dispense my non-steroidal anti-inflammatory. And in the beginning, I think I just, and I think I'm as guilty as this as anybody is, we kind of almost handed it out like candy. It's like, hey, you know what? If he does well on this, let's just leave him on. And then as time's gone on, I've had a train wreck or two, and I've gotten schooled, so to speak. And so now I'm trying to do a little bit more with, let's put him on for every day for 2 weeks, and then maybe we'll go ahead and put him on every other day for a couple weeks and see if you can get down to a lower dose. In other words, I'm trying to control their pain, and I'm trying to control it in such a manner that they're not that their liver or kidneys aren't having to process this stuff on a everyday basis.
Well, I think there's 2 points there, maybe 3. The first is, I think there are a lot of times when we as a profession are not recommending NSAIDs continuously enough. And for me, being a pain management guy, I really think that if dogs are painful 3 or more days a week, they should probably be on their NSAID every single day. Otherwise, they're comfortable, people stop, they get uncomfortable, and we keep chasing them. And those dogs will end up with really a much greater likelihood of having problem chronic pain that then doesn't respond to an NSAID anymore. On the other hand, there are patients who really can go weeks or months at a time without any pain. And those are the dogs I think is very appropriate. They get painful, whatever they've done, pulse them for days or weeks and stop. I also think that your approach is so sound that, especially with an NSAID, we should really be looking at the lowest effective dose. So we start out at some bottle dose and then work our way down. And I think a lot of the patients don't really need, a full dose every day.
Right. I also think there's this subset of dogs. In fact, I'll tell you a little story. I had one client that moved from Battle Creek to Chicago, but they would come home. Their family still lived in Battle Creek, so they'd come home and they'd bring their dog home every Thanksgiving and see me, and I'd look at it. And they got a little bit older and had some arthritis, and I said, "What are you doing?" And they're like, so they show me that they've had X-rays taken, and they bring the whole history back with them, and they're on non-steroidals, and they're on holistic things, to try to help with the arthritis. And they said, well, we just don't think our doctor in Chicago is getting down to the point of this. And I said, well, it looks to me like your doctor's done a really good job of figuring this all out for you. I said, if I had any advice for you, I'd say you get about 15 pounds off this dog and then see how this all works out. Well, the client, they leave there. They don't say anything to me. I mean, nice to see you again, yada, yada, yada. They head on down the road, and they come back the next year, and they said, we were so mad at you after last year. And I said, well, we paid a lot of money, and you came in and always told us our dog was too fat and sent us out the door. And they said, we got down by Michigan City, which is about 100 miles away, and they said, maybe there's something to it. So they went home and they got the 15 pounds off the dog, and they came back and they said, told them, that was good information. And they said, that was the soundest information we'd had. And I said, well, somebody had already done all the obvious things, and this was still obvious, but less obvious. And I said, I think the weight thing is a big deal, and I think you can in fact, I think there's a lot of these dogs that need to lose weight almost as much as they need a non-steroidal anti-inflammatory.
Right, and being a guy who sees 10 arthritis cases a day, that weight component is huge. Dogs who are even 10% overweight need a lot more drug therapy than dogs who are at their appropriate weight. And we can flog dogs with drugs for weeks, months, years, and never get them appropriately comfortable if we don't get their weight down. Of course, that's usually easier said than done, right? It's, you tell an owner, feed less, whatever. It doesn't always happen. But I actually have pretty high success with weight loss. One, I give owners a 30-day target, which works really well. I tell them to feed 25% less. We're looking for 3% weight loss over a 30-day period. And then I tell them, if that doesn't work, we're going to use a dog-specific appetite suppressant to get the weight down. And I never really talk about obesity. All I talk is about the solution to getting your dog comfortable is to lose weight. part of the solution. And it's really, when I talk about multimodal approaches to pain control, osteoarthritis, weight loss is the #1 thing.
I think this is a good discussion today, because I've, the pain control thing is, it's not funny, but years ago when you first start practice, you'd wake up and you'd be in a surgery room and things would be waking up and kind of whining and stuff. Now you can go in there and take a nap, so you guys in anesthesiology have done a great job with the rest of us, teaching us. Well, and keeping us on the straight and narrow, and that's been really good. It's something you really don't embrace that much when you first start hearing about it, but over and over and over and over again. And then when you start seeing the results, that's the caveat right there, is when you start seeing the results. So.
Yeah, the profession has come a long way since I went to veterinary school.
It has, yeah.
And a good direction in that.
It has. Yep.